the nucleotomy, and I'll be talking about the basis of nucleotomy. Dr. Ikeda will be talking about the soft cataract and a posterior polar cataract. Then I'll be taking up the hard cataract, wide intervention cataract nucleus removal. Our talk should be totally focused onto the removal of the nucleus only. We know that if there was no nucleus, probably we would have not needed the phaco machine. Rest of the steps can be done without the phaco machine. So we will be covering up. First and foremost is we need to understand the anatomy of the nucleus, which is concave backwards. So when we are trying to trench it and break it, this has to be kept in mind. That means the trench has to be deeper in the center. And all the procedures are to be performed into the central safe zone, where there is a maximum space in the eye. The cornea is convex forward, capsule is concave backward, so there is a maximum fluid and maximum safety is available here. Nothing should be performed into the periphery under the capsule, because the capsule is very close and the iris is very close, the space is less. If you try to suck it, slightest this thing you're closer to the iris will get sucked into it. So the parameters, what parameters we should use will depend upon how good is the anterior chamber depth. If myopic patient, you can keep a higher settings. In a hyperopic and a small chamber, you will have to keep a lower setting. Pupil and iris. The pupil is small, iris is floppy, you will have to have a lower setting. Zonules and lens and nucleus. So nucleus is hard. If you operate at a lower setting, you won't be able to operate, because you just keep on chatting, you will use a lot of energy. And of course, most important is what type of machine you have, what experience you have, what technique you are using. So when we are chopping, we need to have a good hold. So the hold depends upon the vacuum setting and area of the tip. That means if you want a stronger hold, you need to use the regular tip instead of a micro tip. But you don't want a stronger hole in a softer cataract, then you need to have a smaller, a micro tip to operate upon. And flow rate decides how fast the things will happen. So vacuum decides how strongly you are going to hold. Flow rate decides how fast the pieces will be sucked towards the tip. So when you want to remove the nucleus, there are techniques which is divide and conquer, chopping and stop and chop, and there are certain steps like trenching, splitting, chopping and phaco aspiration which you have to master. So this is the divide and conquer, simple technique. This was the chopping, where we used to bury and chop. The advantage of this technique is that phaco energy consumed is much less. And then the chopping came before the stop and chop, because sometimes when you are doing a chopping, you may not be able to separate the pieces well. So we thought, why not to make a trench initially like divide and conquer, split into two, and then go into the chopping mode. So the chopping terminology, most important is the vacuum seal. That means we bury the tip inside the nucleus body and then try to chop it so that it is lollipopped because of the vacuum. And then we have a central chop or vertical chop when we try to do it within the rectus margin. Then another is the peripheral chop or horizontal chop. If I put the chopper underneath the rectus margin, start splitting the nucleus from the periphery of the nucleus, and then there could be modified peripheral chop where the periphery of the nucleus is brought out of the rectus margin and then try to chop from the periphery. And then we normally use the term direct chop when we try to bury the tip directly into the nucleus without making much of the trenching, without doing much of the trenching and trying to chop it, which could be central or peripheral. So for vacuum seal, we nudge at the central part of the nucleus, not very superficial, give little bit of energy. Once it gets buried, then lift the foot pedal up, only the vacuum is on, and hold it over there at position 2. When we are doing trenching, Kelman tip is better because you can make far better trench, and the energy used should be such that there is no pushing of the nucleus and no bubble formation. Depth should be deep in the center. Width will be harder the cataract, wider is the trench. So now if you see this, so we are making this trench which is like your divide and conquer. You can see the cross over there. Once you are done this trenching, then you can split into two. And once these pieces are separated, you can just pull them into the center and finish off the surgery. So this is a peripheral chop. So I usually make a small trench so that I can bury into the depth of the nucleus. You can see the chopper is underneath the rexus margin, and we hold with the vacuum seal. Chopper initially horizontal, then we turn it vertical and then pull towards the tip. Once it comes closer to the tip, we separate sideways to get the split. Once again, we bury the tip, go horizontally, make it vertical, and then as you come to the tip, closer to the tip, just split it. So keep on chopping. Once you have created all the splits, you can just consume them. And the direct chop is also very important whenever the nucleus is unstable, because if you try to make a trench, it keeps on rotating. So after making a small depression, then you can just hold it with the high vacuum setting. I usually prefer to make a little bit of impression over there so that I can bury it deep, but many of them are expert enough not to make this trench and bury it directly. So once I have buried it, then just split it and chop it. So this is a vertical or central chop. We are not taking the chopper underneath the rexus margin. We are doing everything within the rexus margin. So again, our chopper is within the rexus margin. We are burying it down and separating it. So keep on separating the fibers. Keep on separating the fibers. And once again, this is done. So that was the first video I saw was a peripheral chop, and this is a central chop. And when I'm removing the last fragment, I have taken my chopper out so that there is no leakage from the side port, and I have reduced my vacuum setting to 400 to avoid the PCR, because this is the time when there are more chances of PCR. So this is what I call as a modified peripheral chop. So once half of the segment has been removed, now it is possible to bring the another half of the nucleus in front, and I just bury this tip. Now instead of, because the vertical chop is little difficult and you are trying to bury it, so I pull the periphery out of the rexus margin and then chop it. Starting from the periphery, the chopping is much more easier than trying to do the vertical chop. So stop and chop, my preferred technique is a stop and chop, because in a very soft cataract it's difficult to do the direct chop, and in a very hard cataract also at times it is very difficult and easy to master, excellent control, and mostly predictable and reproducible even with the low-end machine. And most importantly, energy used for making trench causes no collateral damage. So this is just a stop and chop technique. So initially, if you will watch, we have removed the part of the epinucleus covering the anterior nuclear surface up to the rexus margin. And once that is done, we will make a trench. So the first we remove the epinucleus, which is lying on front of the top of the anterior nuclear surface. Then we make a little wider trench. And the most important is the depth of the trench. Up to center, a little bit sub-incisional trench. If you are able to go up to the center, 1 millimeter on this side of the center, sub-incisional is fine. You can see still the central part is not trenched. Now you can see that central trench is there. If you are not able to achieve, then you can rotate and trench from the other side. If you are able to achieve, just crack it, and now this surgery becomes very simple. So I think I'll go ahead with, if somebody is in a hurry, he can go. Otherwise, I can cover my second talk as well. Should I cover the second talk, or somebody is in a hurry? Laptop lagana. So she is Dr. Ikeda Lal. She'll be talking about the soft cataract and a posterior polar cataract.
A very good morning, and I will be talking about phacoemulsification in a soft cataract. So what happens really in a soft cataract is the capsular excess can be challenging, as these are young patients, they have elastic capsules. Secondly, while phacoemulsification, we find it difficult to hold on to the nucleus because of the density, and therefore we find it difficult to chop, which can lead to formation of a bowl and lead to a posterior capsular blowout. Now, it helps if we use forceps for capsular excess, gives us better control. Even using trypan blue dye makes the capsule slightly more fragile. It makes it easier to tear it rather than without staining. So these are the two things that might help with the rhexis. When we talk about phacoemulsification, where we have a hard cataract, we tend to operate at higher vacuum settings, and because of the density of the cataract, we get a good hold. Whereas in softer cataracts, we tend to operate at lower vacuum settings, and the cataract tends to cheese wire as soon as we try to hold it. The epinucleus can be quite sticky in these cases, especially it can stick to the nucleus if we have not done a good hydrodelineation, and therefore we might find it difficult to pull the nucleus towards the center to chop, and this leads to tendency towards operating in the peripheral unsafe zone when we are not being able to grab the nucleus in the center, and in turn increases the risk of PCR. So let's look at a few of the cases. There can be different techniques to deal with a soft cataract, and I'll just share a few of my videos. So here, this is a patient who is actually undergoing a refractive lens exchange. There is no significant cataract. I have stained the capsule with trypan blue. I find that it's easier to make a capsular excess when we do that. Then we inject the fluid wave. Doing a good hydrodissection and a delineation really helps. And here we just prolapse one of the poles out, inject some dispersive OVD before we go ahead with our phacoemulsification. So we need a reasonably decent size rhexis for this if we need to prolapse one of the poles up. That is one of the prerequisites for this technique. And here I'm finding it difficult to really access the nucleus sub-incisionally, so we can stop, inject some dispersive OVD again under this pole and lift it up, and then further just emulsify it. So here, since we are using very, very low power settings, lifting up one of the poles in the anterior chamber in a soft cataract can really make our surgery very, very easy. And this is towards the end of the case. So this is the first technique when we have a decent sized rhexis and a very, very soft cataract. Now, so this is a case where rhexis is again, okay, maybe 5 millimeters or so, not too large, but still we are able to prolapse one of the poles out. Here, what I'm doing differently is I have done 2-3 waves of hydrodelineation, and we've really taken that hardcore endonucleus that we can see, we have really delineated that. So this is another technique. When you have a small endonucleus, just with hydrodelineation, lift the entire endonucleus up and then easily emulsify. So this is something again that we can do. So the trick lies in doing a good hydrodissection and a good hydrodelineation so that it makes it easier for us to access the nucleus. And then just in recently lower vacuum settings, we can use the epinuclear mode to take care of the rest of the nucleus and the epinucleus. So this is another technique that can come in handy when we have a slightly harder cataract with a small endonucleus. Now, this is a patient who has not a very soft cataract. Maybe when we have a grade 1 to 2 cataract, it's a slightly older patient. Age of the patient also matters. So if you have, say, a 60-year-old patient with soft cataract, it will behave differently as a 40-year-old patient would. So here what I'm doing is that I'm rotating the nucleus all around and just aspirating the anterior epinucleus to really access the nucleus and free it up. And then going ahead with the traditional stop and chop. Stop and chop works really, really well for soft cataracts, because doing a direct chop, we might find it very difficult to actually hold on to the nucleus. So here, after creating a trench, the trench doesn't need to be too broad or too deep in these cases. We just need a decent sized trench, and then we can safely go ahead and chop the remaining pieces. We can do a peripheral chop and that comes in handy. A horizontal or a peripheral chop comes in handy for these kind of soft cataracts. So this is another technique that we can use, especially in slightly older patients where we have maybe grade 1 to 2 of nuclear sclerosis. We don't have a very large rhexis. We are not able to prolapse the entire pole out. Now, this case demonstrates some of the difficulties that we face with these soft cataracts. So my plan is here again, this is a 65-year-old patient, to make a trench, do a stop and chop. I make a trench, I'm able to crack it, and then I'm just planning to chop it. And what happens, typically happens in soft cataract, is that when I'm trying to hold on to the nucleus, it's just cheese wiring and giving away. So what you need to do to get out of this sticky situation, keep a decently high vacuum settings, lower the power parameters, give very low energy, it's 5% power, and then hold on to one of the poles slightly more anteriorly and periphery, and then slowly and steadily keep giving the vacuum at one of the anterior poles, and then just lift it up. So that is the way to get out of a sticky situation when we are stuck and we end up in this bowl formation, and we get stuck of not knowing what to do. Especially for beginner surgeons, it can become quite challenging, and they tend to try and chop in the periphery, which can lead to a posterior capsular rupture. So again, just hold on to one of the poles that you can grab. Do not decrease the vacuum, just decrease the power setting so that it doesn't cheese wire and splice through. And then the rest of the job becomes easy. So to summarize, all soft cataracts are different. They are not all the same. It depends on the age of the patient as well. An adequate sized rhexis, a good hydrodissection and a hydrodelineation really helps in dealing with these patients. We can use different techniques. Either we can prolapse one of the poles of the nucleus with hydrodissection, or alternatively, we can remove the sticky anterior epinucleus, prolapse the nucleus and emulsify. Can use either direct chop or stop and chop, but I find stop and chop is much more helpful for softer cataracts. When we have formation of a bowl, use low power, moderate amount of vacuum, and just try to grab onto one pole of the nucleus slightly more anterior, not into the substance of the nucleus as we would do for a slightly denser cataract. Thank you. I'll move on to the next talk, maybe then we can have a discussion. So my next talk is on posterior polar cataract. I'll just demonstrate a video on different posterior polar cataracts. So here the first case is a patient who has a nuclear sclerosis and has a high hypermetropia with the pterygium. We can see the IOL power is 36 diopters. Thankfully, the aqueous depth is adequate, and he does not have significant astigmatism. He's not concerned about the pterygium at all. He just wants cataract surgery. So here, what we need to do is we are going ahead with the cataract surgery alone, and the rhexis in posterior polar cataracts needs to be a decent size, maybe 5.5 mm, but not very large, because if we end up in a posterior capsular rupture, we need a good, adequate sulcus support to be able to implant a 3-piece IOL. Another thing we can do is keep a 3-piece IOL as backup for these patients, although for this patient it was not possible because this is a 36 diopter IOL. Now here what I like to do is do a slightly limited visco dissection, just going ahead with my visco cannula and injecting a little bit of a dispersive OVD, very, very small amounts under the anterior capsule before I do a hydrodelineation. So how this really helps is that it avoids an inadvertent hydrodissection while doing a hydrodelineation, because that OVD gives a little bit of resistance to the path of the fluid, and also helps in mobilizing the nucleus slightly. And then, since this is a grade 2 nuclear sclerosis, I want to be as safe as possible, trying to keep the parameters slightly lower than at what I'd usually keep, and creating a trench, going ahead with a stop and chop. So here, when we crack, we have to be gentle, not too vigorous. Here, I'm not trying to rotate the nucleus. Again, we need minimal rotations. We just need to gently nudge on the nucleus and prolapse it up and then chop. So again, we should avoid a vigorous rotation of the nucleus. Any maneuver that can cause stress on the posterior capsule needs to be avoided. So typically, I just nudge the nucleus of one of the poles, lift it up, and then just chop. So this, again, these are slightly softer cataracts. These patients tend to present early. We are not dealing with very hard cataracts when we are looking at posterior polar cases. And before we withdraw our infusion cannula, before I really withdraw the phacoemulsification probe, important to not let chamber collapse. So I'm injecting OVD from the other side. Another thing I like to do is that before I remove the epinucleus, I inject some dispersive OVD behind the epinucleus, and this helps in two ways. One is if there is a PCR, it tends to plug the PCR, gives me more safety, and also it helps in really prolapsing that epinucleus up. So these are the two ways in this technique really helps me. And again, as before I withdraw my irrigation, I am injecting OVD, and then thankfully this patient has an intact posterior capsule, and using a bimanual irrigation aspiration. Here if we see a few fibers which are really stuck in the center to the area where the posterior polar cataract is, we should avoid the temptation to try and polish it as much as possible, because these capsules can be extremely fragile and they can rupture even though everything has gone well. So here we implant a single piece hydrophobic IOL in the bag, and the case is done. Now, this is the left eye of the same patient undergoing cataract surgery 1 week later. This is a slightly less dense nucleus as compared to the other eye. So here my technique is slightly different. I'm going ahead with the trench. The trench also doesn't need to be that deep or broad. And I've just lifted up the entire nucleus because we have removed the anterior epinucleus after creating the trench and just emulsified. So this is something else we can do, especially when we have soft cataracts. Again, one of the techniques that I discussed in soft cataract management as well. So again, depending on the amount of nuclear sclerosis, we need to be careful, and this is the end of this case. Now, what do we do when we have a posterior capsular rupture? About 10% of these patients can land up in posterior capsular rupture. So this is one of the patients in this, in which we face this issue. So starting with following all the principles that I previously discussed with the posterior polar cataract, I am not being very vigorous. The parameters are slightly lower than what I would normally keep for this kind of a cataract. And no vigorous rotations. I'm just nudging the nucleus and emulsifying it. I'm being very, very gentle in my rotations. So here everything seems to be going well. The nucleus has been emulsified almost completely, and then I'm injecting again dispersive OVD before I come out, injecting dispersive OVD underneath the epinucleus as well. But as I am aspirating the epinucleus, I feel that something is not quite right. And once I aspirate the whole of the epinuclear plate, I see that there is a posterior capsular rupture right over here. And this is where before we come out, we just inject some little bit of HPMC again. So this is very well visualized over here. We have a posterior capsular rupture. So going ahead with anterior vitrectomy first to clear up all of this vitreous, but we see that we have significant amount of cortex still left, and it can be very, very difficult to maneuver this cortex with the vitrectomy probe when we have so much of cortex left. So what I like to do is that after we have done a thorough anterior vitrectomy, we are sure that there is no vitreous in the anterior chamber. I've switched back to my irrigation aspiration bimanual probe, and then aspirating the cortex, making sure the chamber is stable. We are not operating at a very high vacuum settings. Again, every time before I withdraw my infusion cannula, I am injecting dispersive OVD to make sure that we do not end up causing vitreous relapse in the anterior chamber. Now a little bit of this cortex, before I aspirate, I'm again doing a vitrectomy just to make sure that there is no vitreous, and then I'm using a vitrectomy probe to get rid of this a little bit of cortex. And now in this case, using a 3-piece IOL in the sulcus, so it is very important when we are planning these patients to tell them that we might have to change the plan intraoperatively, and we might have to put a different IOL for you. And so keeping this 3-piece IOL, adjusting the A constant for sulcus and keeping it in our inventory becomes extremely important. You can do an optic capture and then remove the rest of the OVD. So just wanted to share a few of the cases and this kind of complications that we have encountered, and my technique for posterior polar. Thank you.
We'll take up the questions at the end of the session. Now I'll invite Dr. Rajesh Sinha, Professor, RP Center, All India Institute. He'll be talking about the nucleus removal in presence of the corneal opacity.
At the outset, I would like to thank Dr. Harbans Lal sir for inviting me in this course. I'll be talking about nucleus management in eyes with corneal opacity. Now, whenever you have corneal opacity or haze, the problem is the issue of visibility. And the aim of presentation is to discuss methods to enhance visualization so that we can perform the procedure appropriately. So first and foremost thing is the pupil should be well dilated. If you have a small corneal opacity in the center, you even with a mid-dilated pupil, in a routine cataract, if it's a 5 millimeter pupil, you can manage and you can go ahead and do the surgery. But if it's a small central opacity, in that case, you would like to have a larger pupil. So that's very important. Preferably should be done under periorbital block because sometimes you have to manage a little bit of this thing. You may have to manage the iris and the patient might have pain. You can use intracameral drugs to reduce pain. And it is best performed when the opacity is only partly covering the cornea and in a nebula or nebulomacular opacity. We all use strap and blue dye for white cataracts, but in cases of corneal opacities, we should use it for a longer period because it not only helps in doing a good capsulorhexis, it maintains that stain even during the nucleus chopping. That's why we will not be, we will save the margin of the capsulorhexis while chopping if we see it directly. Another important thing is that if you have an opacity like this and you are doing a capsulorhexis, then when you are holding the capsule, you should not leave it behind the capsular opacity. As I'm trying to pull it beyond this opacity, bring it here behind a clear cornea and then hold it again and then complete the capsulorhexis. Another important thing is that you should do a very good hydro procedure in such cases. The nucleus should be nicely mobile so that you don't have any issue as far as chopping is concerned. Another important point is that in order to enhance visualization, you can use viscodispersive viscoelastic on the cornea. It's better to save the endothelium by using these chondroitin sulfate inside the anterior chamber, but on the cornea, when you put a viscodispersive viscoelastic while you are chopping, suddenly it improves the visualization and you are in a better position to chop and you don't damage the capsule. As I said, OVD on the ocular surface, corneal surface is important. As I had mentioned earlier, if there was no opacity, even with a hard cataract like this, which is a black cataract, you could have managed with a 5 millimeter pupil. But if there's an opacity like this, in such a case, it's better to use a hook so that you can see the peripheral part of the nucleus as well and go ahead and do the chopping and complete the procedure. Another important thing to enhance visualization is the use of endo-illuminator. Endo-illuminator, which has been used in the retinal procedures, can be used in eyes where there is corneal haze. And you can ask the assistant to hold the endo-illuminator from outside so that while you are chopping, it will enhance visualization and you may not accidentally chop the nucleus. And once you have done the chopping and you are holding the epinuclear plate, you can take the endo-illuminator inside so that you can hold this epinuclear plate nicely and take it out and completely aspirate. So endo-illuminator is really very useful in managing such cases. Chandelier illumination in cases of corneal haze, sometimes sometimes you have even greater haze than this. Chandelier illumination gives a very nice glow and you manage it very well. I'll just show you another example of the use of chandelier illumination, wherein when you get a nice glow with the chandelier illumination, then you can see the rhexis margin while you're doing the capsulorhexis because you are getting a nice glow from behind. So that is very, very useful in cases of corneal haze. And when you are chopping also, you can see the nucleus pieces nicely under this glow that is coming from the chandelier illumination, and go ahead and complete the procedure. If there is an opacity like this, and if you have a provision for corneal surgery, you can definitely go ahead and do an anterior lamellar keratoplasty in this. You can remove this, cut it with a microkeratome, and once you cut this, you can see the opacity clears up visualization improves. You can put viscodispersive viscoelastic on the ocular surface that will further enhance visualization. You can put trypan blue dye to further enhance visualization and go ahead and complete the procedure, and then of course put the donor tissue over the cornea to complete the procedure. Another situation wherein there is a very bad opacity, vascularized opacity, the other eye is thiesical. You can see the opacity is more dense up to 80 micron, up to 80% of the cornea. So if you dissect up to 80% of cornea, you will be in a position to perform the cataract surgery nicely. And you can do a routine phacoemulsification, and then as you can see here, 80% of the cornea has been dissected. Now the visualization, as it was earlier, it was absolutely opaque, hazy. Now the visualization has improved significantly, and you can go ahead and complete the procedure with under direct visualization. So the basic aim of performing all these procedures is to perform it with good visualization, and the aim of this presentation was to discuss the methods to enhance visualization in presence of corneal opacity by using trypan blue dye for a longer period, so that you can, while chopping also you don't chop accidentally the rhexis margin. Use of viscodispersive OVD on the surface, use of endoilluminator or chandelier illumination, and lastly but not the least, in an opacity like this, if you have done a cataract surgery, you can do a small sphincterotomy in this area so that it doesn't come to the IOL edge also, and it will provide a small pupil adjacent to this, which will provide much better vision. And we had published this article long back in the year 2004, wherein the results had shown the patient showed very good improvement with those sphincterotomies. So thank you very much once again for this opportunity.
For wonderful demonstration of various grades of corneal opacity and how to manage them. And I will invite Dr. Ashok Saraf for his presentation on how to handle the nucleus in presence of intumescent and a white cataract.
Good morning, friends. Dr. Singh, I would like to bring to your kind notice that this use of endoilluminator through the anterior chamber, it was present in AIOS way back in 2000, I think 2002 or 1, and we have given the name Moonlight Phaco. It's an excellent procedure, and the chandelier is also excellent. Very good videos. Thank you very much. And हाँ जी सॉरी अभी बताओ थोड़ा सर कौन सी आपने देखी okay. So thank you very much, Dr. Harman Sal, for inviting me for this course. Thank you very much. I would like to share, you already covered so many points, but still I would like to go ahead with the, how do we do when there is a cataract which is white and intumescence. I cannot go forward. Okay. The white swollen lens, it appears as a mature cataract, maybe a hypermature, or there may be a very small nucleus cataract, Morghian cataract. There are challenges, as we have seen. The capsule is thin, fragile. There may be elevated intralenticular pressure. The lens may be of a large size, so you have a less working space. The epinucleus may be dense, so there is a less cushion effect, and the weak zonules there may be, and that can lead to PCR and drop fragments. Intraoperative consideration when we are dealing with this, we must be very careful during the rhexis, and before that we must do the debulking. There are various methods. or otherwise, if you are not very happy or not comfortable, you can make a small rhexis first and then enlarge. And hydrodissection may not be necessary if the cataract is very soft. And phaco, as mentioned, use low powers, but it is very important to maintain the chamber. So we'll go with this video. See, now, over a period of time, sir, with due respect, but everybody develops their own technique. There may be combination of stop and chop, direct chop, and whatnot, depending upon the challenges or the cataract consistency, consistency you face. So, depending on the pupillary diameter also. But you can see here, the lens substance is not very hard, soft. So you, as rightly said, you must use the low parameters. And once it is done, it is better to do this nucleotomy in the axis area and at the pupillary iris level. Again, this is a soft cataract. Very easy to crack. I think it depends on the machines also, no? I don't know whether the good quality of machines make some difference. Sometimes the last fragments are very difficult because they go and hiding in each corner of the eyeball, we mean the anterior chamber. So you have to be very careful, very gentle. And when the pupil is fully dilated, it's very, very easy. So, take-home message is there are risk factors in handling such patients, like thin capsule. Cataract may not be hard, but you must take precautions while making rhexis. Must use low parameters when needed, and you should be very gentle doing phaco. Thank you very much.
Thank you, Dr. Sharaf. Now I'll invite Dr. Anurag Mishra. He'll be talking about the nucleus removal in a small pupil.
Thank you, sir, for the grand opportunity. Good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Before we go to the management and the nucleus management in particular in small pupils, let's just try to outline the causes and what causes the small pupil occurrence in those situations. Basically, these are all systemic conditions. PXF, pseudoexfoliation syndrome, causes a generalized atrophy and muscle deposits on the dilator, both the dilator and the sphincter and the sphincter muscles. That's the reason why it causes small pupil. IFIS causes a dilator muscle atony and thereby causes an atrophy of the same. Synechia or membranes mechanically restrain the pupil from getting dilated, and that's the reason why they cause small pupils. Sometimes it's age-related because tissue atrophy is generalized. All tissues of the body get affected, including the knee capsules and the ligaments. That also doesn't spare the muscles. And in diabetes, there occurs metabolic changes in the sarcomeres for which it becomes kind of rigid. The resurrective measures, these pharmacological agents, we now have excellent intracameral agents too, which cause a pupillary dilatation or maintain that if it's even slightly dilated. OVDs, there are different types of super heavy OVDs, and They cause a mechanical, they cause a bulk and sit on the pupil to mechanically dilate it. However, it doesn't stay for too long. Cyclitic membrane, if it is there and restraining the pupil from getting dilated mechanically, it must be peeled. Synecholysis, if that's the reason for the small pupil to come in, it must be lysed. And of course, there are expanded devices, and we will take a look at the expanded devices, and we're very proud for being Indians, because 3 of those expanded devices are from India. This is the first case wherein there is a cyclitic membrane and there's synechia as well, because this is a uveitic cataract. So I'm doing the synecholysis first and then peeling off the cyclitic membrane. Just look at the pupil, the way it behaves after that. The restraint is gone, and the moment you put in the viscoelastic, it just expands, so it doesn't need any pupillary devices. But if we would not have done those initial procedures, taking 10-15 seconds time, then we would have had probably to use some expanding device. This is the age-old true friend of ours, the iris hooks, polypropylene hockey stick-shaped hooks, which go in through the side port incisions. The way they should go into the eye should be parallel to the iris surface. Then they should be rotated, and then the stopper should be tightened, and it produces a rectangular kind of a shape. And the 5th hook is optional. It might be applied subincisionally or not, but this is the way it should go in, and the reverse should happen when they would come out. The most trusted pupillary expansion device in my practice is the Milligan ring, and I'm sure that a lot of people would agree with me that this is the most solid ring, the most robust device that dilates even the most rigid of pupils. Made up of polypropylene, it has got 4 hairpin scrolls. 3 of them are actually engaged as the ring comes out of the plunger, and the 4th ring has to be engaged later on, introducing a Sinskey hook from the side port cannula. It produces excellent pupillary dilatation. There are 2 types, 6.25 and 7. 7 is a little more difficult to maneuver, but 6.25 is a fantastic device. This is the first device that we would be talking about, which is from India. This is the Gupta's ring. It's, the material is PMMA, but the disadvantage with this is you need a 2.8 millimeter section to put it in. It doesn't come as a preloaded device, so you have to load it just like an IOL in a butterfly cartridge. And the other thing is there is a junction in one of the shafts, and the junction sometimes snaps inside the eye, so it might just injure the. So technically speaking, the build quality is not as robust as the Milligan is, but it looks like the Milligan and mostly works like the Milligan as well. This is the Gupta's ring. This is the B-hex, the most slender of those 5 devices that we would be talking about. It gets in even through a side port. Polyamide made, extremely thin profile, and it doesn't have 2 vertical profiles. It has only 1 vertical profile. There are alternate flanges which need to be put into the iris, underneath the iris. Produces are 5.25 to 5.5 millimeters dilatation, but the disadvantage with this is too slender a device to have any tensile strength. So if it's a very rigid pupil, you have to stretch the pupil first mechanically before putting in the B-hex. Otherwise, it doesn't work, and the pupil also becomes very distorted and asymmetric in very rigid pupils. The last of the, this is the Visitec eye ring, not from India, of course. This is a polyurethane ring, and it's got hinges. So when it goes into the eye, if you look at the hinges, the way it unfolds, beautiful device. The only thing is the width is a little thicker than where I would want it to be, but it's very, very flexible indeed. It's got a groove all around it, and there are holes holding which you can engage it in the pupil. The most rigid pupils are very effectively dilated, but because look at the way it bends, because of the hinge effect, it bends really, really hard and goes right to the center of the pupil. The last of these devices is called the iNova, which has come recently from Orolab. This is a silicon device, and it's a round device, preloaded, but the plunger doesn't work very well. It sometimes opens in a figure of 8 pattern inside the eye. But once you engage, this is the device that causes the most circular pupil inside the eye once you get it engaged. The other devices make the pupil somewhat rhomboid or rectangular, but this renders the pupil very, very circular. Again, the disadvantage is it's a very bulky device. So if you have a shallow AC, This is not the device to be used in the eye. The question is, once you have a dilated pupil, the nucleotomy is a routine nucleotomy. Soft, hard, moderate, whatever. But if you do not dilate the pupil, until what point you should not be dilating the pupil? In my opinion, that would vary from surgeon to surgeon where your threshold lies. But if you have an ATIL to be placed, a toric or an EDOF or a trifocal, different lenses have different diffraction or wavefront designing surface changes. And if you have a pupil that does not react to light the way it should postoperatively, then you might not yield the same desired result. So in some cases, you should be able to handle the nucleus even with a small pupil just to keep the aperture function intact postoperatively. So this is one such case. And if you want to do the nucleotomy in the presence of a small pupil, there are a few tips. The second instrument plays a pivotal role here. When you're chopping it, it should go rubbing against the nucleus so that you don't engage the anterior capsule, because some part of it will be blind. We all know that. And once you disengage, the second instrument goes and kind of levitates the nuclear portions out of the bag. And the second instrument's positioning should always be ahead of the nuclear probe or the phaco needle. Because the other risk which is unforeseen when you're beginning your nucleotomy is the moment there is a vacuum, the phaco needle gets released of the nucleus substance, the residual vacuum pulls the pupillary margin. So it's very close to the phaco needle. So that's something you should protect that with the second instrument. And after the nucleotomy is finished, the other procedures also can be done in similar manner, retracting the pupil with the second instrument. So if you are handling the nucleus or thereafter the other tissues in the presence of a small pupil, the left hand, which is usually the non-dominant hand for most surgeons, has to play a pivotal role for its positioning and doing the procedure effectively. Thank you so much for your attention.
Thank you, Dr. Anurag. Now I'll invite Dr. Rajiv Chaudhary. He'll be talking about management of the nucleus and subluxated cataract. Dr. Rajiv Chaudhary.
इसमें वीडियो प्ले करने का है तो वो इसमें प्ले हो जाएगी कर्सर के साथ। हाँ इसमें है वो मिलेगा ना। Good morning friends and thanks to Dr. Harbans. My topic is in a subluxated cataract. You see in the small pupil hard brown cataract, sometimes you encounter with this type of the nucleus. This may be soft, this may be hard, this may be brown. So these are really a challenge for us. We just leave apart the causes and all this. We just land up directly into the management. And management vary with the degree of subluxation, 3 degree, 3 to 5, 5, 7, 7. So in this we have multiple options. We do the slow phaco with the CTR or a pars plana vitrectomy or iris club. Excuse me. I need cursor there. इसमें कर्सर था वो वही लगा दो ना मेरा डायरेक्ट नो इसको फॉरवर्ड फास्ट फॉरवर्ड ही करना रहेगा ना। अब ये हटा दो ना डायरेक्ट लगा दो ना। हाँ तो फास्ट फॉरवर्ड कैसे करेगा तो बाहर चाहिए ना इसमें है ना मेरे प्रेजेंटेशन में। फास्ट फॉरवर्ड बार नहीं आ रहा है ना इसमें। नहीं बार नहीं आ रहा ना मेरा प्रेजेंटेशन डायरेक्ट नहीं लगेगा। इसको हटा दें अगर इसको बंद करके डायरेक्ट वो लगा दो तो
far as possible. And once these cracks are made, the nucleus will become loose. I'll pick up the central part of the nucleus first and then remove the rest of the part. So this I am holding it, and I'm just holding now the superficial part of the nucleus. I'm not trying to crack, not trying to split into two, because I feel I failed into split into two. So I have an alternative method. Now I'm just lifting the central part of the nucleus. Once this central part of the nucleus comes out and it is emulsified, then it's very easy to remove the rest of the pieces which were there. So this nucleus is now loose because the split are gone behind this nucleus. And you can see that instead of taking out whole of the nucleus, I just remove the central core of the nucleus first. Tinku. Then now you can see that the fragments which we had cracked now can be easily taken out and without any difficulty. So even at times you are not able to get the two cracks, but in this method you will see that all the procedures are performed in the central safe zone. Nothing we have performed in the peripheral part. So now I'll invite Dr. Tinku Bali. She will be talking about, she's a vitreoretinal surgeon, but she does a lot of cataract surgery as well. So she'll be talking about nucleus management in presence of the posterior capsular rent.
As we all know, posterior capsular rupture is one of the most feared complications of cataract surgery, but if managed right, you can have excellent visual outcomes. The first thing is not to panic, but to organize yourself, and not only yourself, but your OT staff should also be very familiar with the instrumentation needed and how to seamlessly switch between the different modes of your machine, how to switch to the vitrectomy cutter. So that is the most important thing. Now the goals of management are firstly to avoid losing the lens, to remove all the accessible lens material, if necessary perform a proper vitrectomy and avoid enlarging the capsular opening and preserve capsular support. So as in a war, and if you want to win the war, the most important thing is that stop but do not retreat. So similarly, do not panic and withdraw the phacoprobe, because a PC tear does not equal to a ruptured anterior hyaloid face. Once you reflexly withdraw the phacoprobe, you tend to rupture the anterior hyaloid face and prolapse the vitreous. So it's very important not to have hypotony and maintain a very stable anterior chamber. And to do that, what you should do is, once you see a PCT happening, keep your phacoprobe inside and from the side port inject viscoelastic. Once you have a well pressurized stable chamber, that is the time when you withdraw your phacoprobe. So at no point of time should the chamber be allowed to collapse, or the eye should become the eye should not be allowed to become hypotenuse. After that, you should do a thorough anterior vitrectomy. Now, to do a vitrectomy, the chamber should be a closed chamber. So suture the main wound, make another side port, and do the vitrectomy through from your side port. Always remove the vitreous before you remove the lens fragments. Use the highest cutting rate that your machine supports and a low vacuum. You should use the cut IA mode to remove the vitreous. So here is a resident who's operating, and you see how the chamber, this is the resident going in through the main port. You see the chamber is so unstable, there's so much hypotony, and the more hypotony there is, the more vitreous keeps prolapsing in front. The way to do it is like this. You see this tight, stable chamber, and the cutter is being used through the side port and the infusion through the other port. Another important thing is to respect the vitreous base and to avoid any vitreoretinal traction. So do not use Varna scissors or sponges to pull the vitreous, because pulling the vitreous here can induce a very small tear here, and you can get a retinal detachment even months after or even years after the cataract surgery. It's very common once you've had any kind of manipulation to get an RD later on. Nowadays, it is of advantage to shift to the pars plana. So you can always, talk to your vitreoretinal colleague, and you can do the vitrectomy through the pars plana. This is an older video where we were using the MVR blades to make the sclerotomies. But now we have the cannulas, the 23 gauge and the 25 gauge cannulas, which are very easy to insert. So the advantage of the pars plana route is that it reduces the vitreoretinal traction. It gives you better access to the remaining lens material, and you're less likely to damage the capsule once you go through the pars plana. So there are initial, there is a slight learning curve, but once you know how to do it, it's a pretty simple procedure. Nuclear management, if you have a very small phaco piece of nucleus, you can continue the phaco after putting in a dispersive viscoelastic. If there is a larger chunk of the nucleus, then you would have to enlarge the incision and manually remove it. And if there's a nucleus drop, of course, you'll have to refer the patient. Now, another good technique that has been talked about in recent years is the IOL scaffold technique. So once you have a PCT, once you notice the PCT and you have a few remaining nuclear fragments, you can insert the IOL. You can go behind these nuclear fragments. First of all, pressurize your chamber. Manipulate these pieces so that they are more superficial in the anterior chamber. And just forward it. So here you see the IOL being inserted. This is going in behind the nuclear fragments. And once you have your IOL in the sulcus, so then you're safe, and then you can, after that, either with phaco or manually remove these nuclear fragments that are in the anterior chamber. If soft lens matter is present in the anterior chamber, you can use the suction mode of the cutter after doing the anterior vitrectomy, and using the suction mode itself, you can remove the soft lens matter. So this is just the suction mode of the cutter, and you see how nicely the soft lens matter is removed. Now, in case the fragments dislocate posteriorly, it does become, especially if there's a full nucleus that has dropped, it is a dire complication for the cataract surgeon, but a fairly straightforward problem for the vitreoretinal surgeon. And we all know that we don't have to chase after the nuclear fragments, avoid unnecessary manipulations to prevent vitreous traction and consequent retinal detachment and CNV. So what you should do is do a thorough anterior vitrectomy, ensure that there's no vitreous in the wound. And in case you do not, if at that point you do not have the required instrumentation to do an anterior vitrectomy, then just leave it alone. Your posterior segment colleague will take care of that vitreous which is in the anterior chamber, but do not try to mess around or pull the vitreous or use varnas. Just suture the wound and leave it at that. It's also important to retain good capsular support. Now, IOL placement, you can implant an IOL even after a PCT, but make sure that it is stable. If you feel there is any doubt on the stability of the IOL, then do not implant it. And an AC IOL should always be avoided when there is a dropped nucleus, because many times when the vitreoretinal surgeon is doing that, AC IOL tends to drop back. So just a small video showing you, I will just forward it and show you. So this is the lens being implanted in the sulcus. You see there is some amount of posteriorly dislocated lens matter, but you can put in the IOL in the sulcus, and then if it's a very soft lens matter, sometimes it even absorbs over a period of time. It's just the epinuclear material. So after you've inserted the IOL, then constrict the pupil and stain it with tricort. Do not put tricort before you have constricted the pupil, because most times this tricort goes behind and causes IOP elevation in the post-op period. So this is the way to do it. Once you've constricted, here any residual vitreous that is in the anterior chamber can be removed. Wound closure again is extremely important. Before referring it to the vitreoretinal surgeon, ensure that the wound is stable and the chamber is not leaky, so that there's no further prolapse. Every cataract surgeon should have an arrangement with your vitreoretinal colleague in case you ever require him. So you should both be comfortable with each other. You should be able to refer to your vitreoretinal colleague. So always have someone in mind that you can refer these patients to. The vitreoretinal surgeon, again, whenever you're referring a patient with dropped nucleus, do give the requisite information to your vitreoretinal colleague about how much lens matter would have dropped, did you do any maneuvers, whether you tried to implant a lens, whether there's a lens present there or not, and also the IOL PA in case the IOL would need to be implanted after the surgery. Now, a dropped nucleus can be managed in the same sitting if you have the facilities, but it can also be deferred. And there have been so many studies which have shown that the outcome is no different even when the case is taken up as late as 2 weeks after surgery. So there's no need to panic and go in, refer the patient right away. You can wait for the corneal edema to go down, for the inflammation to subside, and the retina colleague can operate it in any time in the first 2 weeks. So to conclude, the important points are firstly, not to panic and withdraw the probe, inject high molecular weight viscoelastic, reduce the border height, manage the nucleus appropriately, do a bimanual anterior vitrectomy, place the IOL appropriately if possible, if you feel it is stable, and most important, do not chase the nuclear fragments. So minimum, whenever there's a dropped nucleus, then minimal intervention is the best option. Simply clean up the vitreous, place an IOL if possible, suture the wound. And a vitreoretinal consultation can always resolve a dropped nucleus with minimal morbidity and excellent visual outcomes. Thank you so much.
Thank you, Dr. Tinku. So with this, we come close to the end of this session. If anybody has got any particular question, he can ask. Otherwise, we move on to the next session. Okay, thank you. Bye-bye. See you.